Yeah. So with the greetings from the institution where you are now. So the examination I just ran through, and the history and everything I have omitted because for want of time, so that we'll concentrate on more on what is very, very important. So always this confusion in some institutions, they say that gate should be told first, and some institutions they say it is last. So which is more logical. So if you see this, it is place. This is a straightforward gate. So all of you can say that this is a case of when the patient walks in, we all know that it is a case of ankylosing spondylitis, full C-curve, spine, stiff, and everything. But if you see this boy when he's walking, so he's so carelessly walking. So very careless attitude. So he walks. So can we say which hip is what? Even if I say that, you can just observe again. If I say that the left hip is involved, can anyone comment on what hip, what gait it is? It is very, very difficult to know. So if you say gait as first, here in our examination, you know that this is a long case, in case that the patient is made to lie down. I feel that it is no point in seeing the gait first, making him walk, making him painful, and then starting to examine, because we will not have any other information. So I feel that gait should be told to the last, so that we will have all the data with us, and then we can go ahead and then do what it is. So the same gait we will come to it later when we see that. So in general examination, you have to say a few things. General condition, height and arm span, ligament elasticity, maintenance criteria, the obvious markers, neurocutaneous markers like anything, and the intelligent quotient and the secondary sexual characters, depending upon what case we are dealing with and what age. So on standing, don't say standing, sitting in lying down. Definitely you have to say when it is hip. Don't say for an elbow examination, I examine the patient on standing, sitting and lying down. Hip case you have to say. And few points which you are saying in standing, don't repeat it in sitting, and don't repeat the same in the lying down. So when you are standing, what are the important things what you have to say? Both the head is at the center, shoulders at the level, whether there is any coronal plane or sagittal plane deformity, legs, scoliosis, kyphosis, there exaggerated lordosis. So this you have to make a mention. So it is an ankylosing spondylitis. You can always say that the what test it is not there. There is which you are seeing. If there is a scoliosis disappeared, it means that functional scoliosis because of the limb length discrepancy. So that you have to say. And then the shortening, if it is there, whether it is in the thigh segment or in the leg segment. That you can say based on the position of the knee, the Alice test or the Gallia's side. So these are the things which you have to say as the patient is sitting. Don't say anything else. Again, don't say head is center, shoulders the same level. Don't say that. Scoliosis is obliterated. The patellar level is receded in the left right knee when compared to the left knee, and then I am examining the patient as the patient is lying supine. So when the patient is lying supine, what are things you have to say as the patient is lying down, both lower limbs together? Exaggerated lordosis, you start from there, whether there is any lordosis exaggerated or not, the anterior spine, attitude, deformity, muscle wasting, and limb length discrepancy. So this four you take in that order. Attitude, deformity, muscle wasting, and limb length discrepancy. The lordosis, the exaggerated lordosis may be obvious in many cases, but it doesn't mean that you are not able to see the light on the opposite side. There is no exaggerated lordosis, because if there is a flabby flank, that might fall down, and even though there is an exaggerated lordosis, you may not be able to see. I am not able to see the light, but in palpation, you will be able to see that the spine is not touching the hand and the knuckles are passing the midline. So be sure that you do the Thomas test just by seeing that the light is not seen. Don't say that there is no exaggerated lordosis. So that is very, very important. The same way, the other thing is also true. There may be a scaphoid abdomen, exaggerated lordosis, but there may not be any fixed deformity. So for that, you have to say that I saw the extension was possible. So this lordosis is only positional, and it is not because of the compensating flexion deformity. This you have to be very, very clear when you are saying. Then the level of the anterior iliac spine, you can say that. And then about swelling, then you come to the hip joint proper. Don't say as a routine, no swelling, no sinus, no tenderness. So those things you don't say routine. So because you can see here, which one is the pointer? Pointer doesn't work. Okay. The pointer. Yeah. So you can see here there is a swelling, obvious swelling. So don't say that blindly that there is no swelling in the scapula spine. These are the subtle signs which we want to see whether you are observing all these things. So whether there is any swelling, scar, sinuses. Looking from front, don't say compartmentalize as I'm looking from the front and you will expect scarpa triangle, scarpa sinuses. Looking from the lateral side. If you say the level of the trochanter, you already know that you are looking at the lateral side. So there is no mass in the posterior aspect. We already know that you have made the patient pro or on the back side. So just this is a professional way of presentation. So scarpa triangle, great trochanter, whether there is anything, and posterior, and never forget to mention about the medial aspect. There was a case of fixed adduction deformity. There was an exostosis proximal femur. The candidate saw supine, the anterior lateral posterior was not able to make out. It was a mechanical cause, extraocular cause, which was causing an abduction deformity. So don't forget all these small things. Just keep your hand on all sides. Then coming to the palpation, exaggeration of upper nodules is very, very important. And you all know that abduction deformity, the anticipital extent at the lower level. So then there may be a question, why is it at the lower level? So do we have that model? So when there is an adduction deformity, the limb is like this. It is not coming to the center. So to keep the limbs parallel, you just lift up the pelvis. So that's the reason you have to say. To make the limbs parallel, the body is compensating by lifting up the pelvis. That is the reason why anticipity explain both. Or the pelvis tilts. So if you can see that, just so all those things you can. So this is the adduction deformity if it is there. So that is what. So I don't want to waste time. Then on palpation, scarpa triangle, warm tenderness, and there is any swelling. Vascular sign of Nara, don't keep it to the special test. Many students they forget to mention about the femoral pulse. So always say femoral pulse. If you want to keep it at the end, you can keep it, but make a mention femoral pulse is equally felt on both sides. And so trochanter, the level surface thickening, broadening. So all those things we make a mention. And the petrochantric and bitrochantric tenderness. So petrochantric is when you keep it bidigital, the trochanter anteroposterior, and bitrochantric is when you press. So this transmitted trochantric tenderness or thrust tenderness is the tenderness which is transmitted along the trochanter, head, acetabulum, that area. So anywhere there is a problem, there can be a tenderness. So always, if it is an obese person, you can make the patient lie down on the lateral side and you can just push it. So that is about the bitrochantric tenderness. So gluteal, always say palm tenderness, the overs point, the posterior expect greater trochanter, lateral 1/3 and medial 1/2, lateral 1/3, that point, whether there is any tenderness. Because recently, everyone are interested in knowing that. So the other rest of the bony prominences you make. Then the demonstration of the fixed deformities. First, always when you want to say about the movement, you start with the fixed deformities. There are no fixed deformities in the coronal plane, sagittal plane, what are the deformities? And then only you go to the movement. Don't go to the movement before telling about mentioning about the fixed deformities. So for the fixed flexion deformity, Thomas test, if you see this, there is an exaggerated lordosis. And this is flexing the opposite side, the pelvis which is tilted grossly, you flex it so that the tilted pelvis is brought down. So what is the mistake in this? Can you say that? What is the mistake in doing this test? Exaggeration of the pelvic, correction of the pelvic tilt. So how do you know that? The ischial tuberosity, it is lifted up. So you have to palpate the ischial tuberosity, find out whether it has gone up. So that is the way you say that. So you have to keep your hand beneath the spine, make sure the spine just touches, and then you flex it till the spine touches, and then see. You should not flex it over, lift up the pelvis, and evaluate the fixed flexion deformity, which is more than what it is. So the fallacies are when you cannot do a Thomas hip knee flexion test, or where you cannot, the body doesn't compensate. If there is a fused spine, then the body doesn't compensate, it will be obvious, apparent, probably in an ankylosing spondylitis. If there is an FFD knee, then it will always be like that. FFD is not compensated, even though it is there. So you have to bring to the edge of the couch and hang the leg down so that the spine normal lordosis appear, and then find out what it is. And then coming to the adduction coronal plane deformity, you can see that this anterior superior spine is at higher level and this is at a lower level. So this you have to correct. So what you do, you just take the limb to the opposite side. When you take the limb to the opposite side, when the anticipiliac spine are at the same level, then what we must do again, you have to try to bring it back to the midline. So if I have an adduction deformity on my right hip, this is my adduction deformity around 15 degrees. So I am not able to bring it to neutral. So to bring it parallel, I have just lifted up my pelvis, so I am keeping it like this. But still, I have some more adduction left. So what do I do to square the pelvis? Keep on adducting the limb. So if I keep on adducting the limb, what happens is, first I exhaust whatever adduction which is left in my hip. So I just do it like that. So once I have exhausted all my adduction, if I still keep on adducting, I cannot adduct. So the pelvis is pulled up. Then both anticipiliac spine are at the same level. But if you measure my adduction deformity in this plane, you are over assessing my adduction deformity. Hope everyone gets this right. So this is 45 degree of adduction deformity, whereas it is only 15 degree of adduction deformity. So what you must do, you must keep your hand on the anticipiliac spine, try to bring it to neutral. The free adduction, whatever it is exhausted. Once this is exhausted, the pelvis starts moving. At that point, when the anticipiliac spine starts moving, that is the point you have to stop and then assess. So whatever it is the fixed adduction deformity. I hope you all get it very clear. So if the examiner asks you to square the pelvis, this is the commonest thing what they'll ask. So when the examiner asks to square, you take this limb to adduction till this comes down. But this anticipiliac spine will not come to the same level till the entire adduction which is left in that hip is exhausted. So that will get exhausted, then it will start pulling the pelvis down. So once both are at the same level, again you have to start bringing it towards midline. Once it comes to the fixed adduction deformity level, then the pelvis will start move and it will not be the movement which is happening at the hip. That is the time when you have to stop and you have to measure. So that is about adduction deformity. So square the pelvis and then measure. So what are the ways? That is one way. So the other way of doing it is, you can, so the free adduction, this Kothari's angle. So this Kothari's angle is one way where you need not do any maneuver, but still you will be able to assess the amount of adduction or abduction deformity. So how do you do that? You just, the prerequisites are it should be a unilateral hip. Bilateral hip, you cannot do this Kothari's line. If it is a unilateral hip, if one side is affected, both limbs are parallel along the axis of the body. The anticipiliac spine, for example, this side there is an adduction deformity. That side is normal. So you draw a line which is perpendicular to the axis of the body. You draw a line perpendicular to the axis of the body from this anticipiliac spine and connect both anticipiliac spine. The angle subtended here. This is the fixed adduction deformity of the left hip. So this is Kothari's method of assessing the adduction or abduction deformity without movement maneuvering the affected limb. It is only possible in the unilateral, not in the bilateral. Rotation, you have to do it both in extension and flexion. So how you do it in extension, it can be by a log rolling method. You have to always see the patellar position and not the foot position, because the inversion, foot adduction, abduction, everything will confuse you. So you have to see that. Then you have to see with the hip and knee flexion. Then the more accurate way is doing in the prone position. So if you see, for seeing the hip rotation in extension, this prone position is always easier. So this with the leg as the pointer. So this is the line, and another line is from this. So this is the amount of what? Internal rotation or external rotation? This is external rotation, always remember. So in prone position, if you do like this, this is external rotation. So this is external rotation and this is the amount of internal rotation. So the line along the axis and the amount, the angle subtended by the leg as a pointer. So this is very, very accurate. Always, if it is possible, this is very accurate. So you can see this. This is log rolling. Don't see the foot because this may look like it is internal rotation. Look at the patella. This is externally rotated. So you can just see that. So you see that this comes just up to neutral, whereas this goes to internal rotation. So this is not internal rotation. This is just coming up to neutral. So left side is affected, you can see. So you have to hold both wire limbs together to avoid pelvis rotating. If you rotate single limb, then the pelvis can rotate like that and it can falsely say that internal rotation is more. So it should be only holding both wire limbs together and then doing it. So how much of external rotation is there in this case? Can anyone say? Can you just guess? What is external rotation? Just tell. What is the amount of external rotation? And this is not a big question. So how much you will roughly estimate? 45, 50 degree. Okay. So what is the fallacy in this? Anyone? Keep in abduction. So that is very good. So you must not keep it in that position. So if you see this, this is the actual amount of external rotation. Hardly it comes to 20 to 30 degrees. So always try to keep the limb in the position in the axis of the body so that you can see, assess exactly what is the amount of external rotation which is taking place, external or internal. So this is the amount of rotation. So try to keep the limb in same plane as the body when there is no fixed deformity. So this is the differential rotation you can see. So this is the position of the patella. You can see that there is a fixed rotational deformity. But when you see that, it is going in for fixed external rotation. So which is coming up to neutral, there is a fixed external rotation deformity. So this tells that in extension, what is differential rotation? So you can see that. So I don't, because of time, I don't want to play it again. So in extension, what is the amount of internal rotation which is possible? In flexion, the internal rotation should be more. Because the element of visual is relaxed, it must be the same or it must be little more than what you see in extension. So if the internal rotation is restricted by more than 20 degrees in flexion when compared to extension, that means that there is a differential rotation or the sectoral sign is positive. So what is the reason for this sectoral sign? The affected portion anterospherical head, which was not articulating within the acetabulum, when it engages the acetabullar cavity, that restricts the rotation. In flexion, that gets engaged within the acetabulum. That leads on to restriction of rotation. So this is the classical demonstration of a differential rotation. Then measurement apparent and true. Apparent is keep along the axis of the body and then try to measure from a fixed point. Bony point is preferable without squaring. So what is the need for measuring the apparent measurement? Why should you measure? It is for prescribing a prosthetic fitting. So if you want to adjust the length, if you want to give a heel and sole rise, it is only after the compensation has taken place. So that is the reason why you do. Then you do the true measurement, squaring the pelvis from anterior spine. You have to keep the other limb also in identical position. So bilateral hip, where you can't square, where you can't keep the other limb in identical position, you must not do. Many students will come and ask or tell that it is a bilateral hip. There will be just tenderness in the hip scarpa's triangle. The other side was fixed deformity with true limb length discrepancy. They will say that I did not measure because it is a bilateral hip. So that is not the answer. So we would expect you to measure. Probably you can also say, because some examiners might say that how can you say that is the true length for that patient. So when you measure, there was a difference of 1 centimeter between these two limbs when after squaring the pelvis. But we will expect you to keep it in the same position. So when the other side, if you are able to keep the limb in the same identical position as the affected side, even though if it is bilateral hip, it is always better to make the measurement. So Brand's triangle is a true measurement. You have to square the pelvis and then do it. Brand's triangle, another point is that you have to take the hypotenuse also, measure all the dimensions of the triangle. It is not only the vertical length, because when it has gone inside, the hypotenuse will decrease, the protrusion, all those things. You have to say that. Then there is one more thing, the apparent length and true length. Always there is a calculation. So when there is an adduction deformity, the pelvis will lift up, so the limb will appear short. You all know. That is the apparent shortening. So you have an adduction deformity, I try to keep my limbs parallel by lifting up my pelvis. So my right lower limb is shorter when compared to the left side. But it is in reality, it is not so. So how much of shortening will be there? Between apparent and for every 10 degree of adduction deformity, roughly as examiners, we'll imagine that there will be 1 centimeter of difference. So if there is an adduction deformity, for every 10 degree, there will be 1 centimeter. For example, if in my right lower limb there is 2 centimeters shortening, apparently, and I have an adduction deformity of 10 degrees, what I expect is there is an apparent shortening of 2 centimeters and a true shortening of 1 centimeter. I expect that. So if you say that apparent shortening of 5 centimeters, true shortening of 1 centimeter, and fixed reduction deformity of 10 degree. So this doesn't work. This equation is grossly wrong. Somewhere you have made some mistakes. So these are the things which you have to balance the equation when you are coming and presenting in your examination. So the same is for the abduction deformity. The adduction deformity and the abduction deformity. Friends, triangle is a true measurement. You always draw dilatance line. Don't say that I could not flex it up to 90 degrees, so I am not drawing the dilatance line. It is easier if you calculate the ischial humerus and celiac spine in flexion and 90 degree. But even if it is an extension, you have to draw. So bilateral hip, this is very important. Shoemaker's line, gene is this, Morris mitochondrial test. And this is the dilatance line, trochanter whether it is gone up or not. This is Shoemaker's line below. And to the side of the deformity, whether it is adduction or abduction, the measurement of the muscle bulk, vascular sign of Nara, Trendle and bulk sign. So this is where the three places where people make mistakes: measurement of adduction, abduction, deformity, Trendle and sign, and the gait. So you have to be very. This is to test the integrity of the abductor. It tests the three components. One is the fulcrum, which is head within the sternum. The lever, which is the head, neck, and trochanter integrity. The power, which is the abductor, effectiveness of the abductor. If any one is gone, then you will have a Trendelenburg sign positive. The Trendelenburg sign, the fulcrum, and these are the things which I have told. So what happens if I stand on the affected normal side? If I stand, you should not ask them to stand like that. You have to ask them to stand like that. So when I stand, my pelvis will try to dip down. What I do is with my abductor, I try to keep it elevated so that my center of gravity is in the place. So if I have some problem in the integrity of this, of any one of this, so what I do, instead of acting on my abductor, I maintain the center of gravity by tilting to this side. My pelvis will droop in this side, I tilt to this side. So this is positive Trendelenburg sign. Again, I tell you, this is affected side. If left side Trendelenburg sign is positive, what I do when I stand on the affected side, normally when it stands, I stand like this, I stand straight. My glute fold doesn't come down, it goes up. And my center of gravity goes to this side. So when there is a problem integrity, so this weight will pull it down. When it pulls down, I have to fall this side. I don't want to fall on this side. So what I do, instead of falling on this side, I tip on this side. So the gluteal fold comes down, and iliac spine in this side, non-weight bearing side comes down, and I tilt in this side. So these three things, you look from the back at the level, look from the front, level of the anterior spine, see the shoulder whether I lurch towards this side. So these are the components. So this we have already seen. The positive, where is it positive? The problem in fulcrum is dislocated hip. The problem in the lever is fractured neck of femur. The problem in the abductor is the abductor when it is lost or in coxavara. Coxavara, why is it so? Because the abductor is normal, but the initial length of the gluteus medius is shortened because of the neck shaft angle getting decreased. So when it is shortened, the abductor lever on the muscle is length is shortened according to Planck-Starling's law. The strength of the muscle is directly proportional to the initial length of the muscle fiber within the physiological limit. So that length when it is reduced, it is ineffective abductor, which results in the Trendelenburg sign positive in coxavara. So it should not be done when there is a coronal brain deformity. The reason deeply and roll your fingers parallel to the inguinal ligament deep. I have not felt one so far, so probably some of you say, but this is what is theoretically being told. So you have to see for parietic and extrailiac nodes. Sacroiliac joint, never forget to. Sacroiliac joint, don't say I did the fibers test, I did the other tests. No, it should not be done. It should be only a tenderness of the posterior iliac spine, a compression distraction test. Because any fiber of matrix test, when you stress the hip, already the hip is affected. So it will be painful only. So don't try to test the sacroiliac joint by doing all these tests. And the spine, shoulders, modified shoulders, everything was knowing. Contralateral hip, lateral knee, and everything you have to remember. Most important is chest expansion. So that is very, very important. So gait, you always split it into component aided, unaided, the stance space, how long it is there, the anterior iliac spine, gluteal fold, shoulder, it is touching to the same side, both hips dipping together, whether the pelvis is rolling or not. So these are the things. So we'll see few of the gaits. So if you can see, what is this gait? So on the left hip, when he weight backs, what happens to the gluteal fold? What is that? What is happening to the right gluteal fold? Every stance space. It is not untouched because stance space is equal. Every time he backs weight on the left side, there is a dip on the right. So this is the subtle, because you cannot, unless you disrobe him and find out what is the gluteal fold happening. So the shoulders dipping on the other side, all those things are very, very subtle, unless your mind is very much trained. So this is a classical Trendelenburg burst sign. Gait. So I'm sorry. That is a very interesting. So can you play on that? Can you just play? Yeah. So what is this gait? Both shoulders you see. How does it go? Every time he walks. So every time the shoulder dips down, both shoulders together. It is not one side dipping. So this is a short limb gait. So on the right side, the knee is always kept flexed in the stance space. So the compensation for short limb task, both shoulders dipping together one, the knee is always kept flexed two, equinus on the opposite side three. So these are the three ways you compensate in the gait in a short limb gait. So all the three is happening. Two is happening. The knee is always kept flexed in the stance space and both shoulders are dipping together. So this is a classical. And this boy who, the left hip if you see, he rolls on the right hip when he's doing a stance space. So he rolls on the lateral side, it is very clear. The pelvis moves instead of hip. So your pelvis doesn't move when you walk like that. But when you see him walking, whenever he's bearing weight on the right side, he rolls over on the hip. So he doesn't walk with the hip flexion which is happening. So there was no movement on the left hip. It was an ankylosing. So that would have been very easy for you to identify if you have examined the patient and then look for the gait. So this is a classical stiff hip. So this is the reason why I tell that you can do it later. So this is another Trendelenburg. You can see right hip when he bears weight, the gluteal fold comes down every time. So this is a classical Trendelenburg gait. Agreed? Right. So this was a question I wanted to ask you. Because of time, I am not doing. And last, before I leave, so the diagnosis in orthopedics or in hip examination is concerned is only four. Whether it can be synovitis or arthritis, or it can be a dorsal vera, it can be an unstable hip, or an ankylosing, whether it is a bony ankylosing or a fibrous ankylosing. How do you say? In synovitis, there will be abduction deformity, the range of movement will be full, the extremes of movement will be painful. So this is synovitis. In arthritis, there will be joint line tenderness. So tell all these points. Don't say that there is range of movement restricted. That's why I say arthritis. So tell from everything. Joint line tenderness, there is a flexion, adduction deformity, there are fixed deformities, range of movement is restricted, available range of movement is painful, there will be true shortening. That is about arthritis. Ankylosis, in fibrous ankylosis and true ankylosis, bony ankylosis, fibrous attempted movement will be painful. In bony ankylosis, attempted movement will be painless. The jog is very difficult to find out. If there is a movement, then probably it goes. But examiners, they can say anything. So bony ankylosis, attempted movement, there is no pain. In dorsal vera, adduction deformity, restriction of adduction internal rotation, exaggeration of, because the arc of motion changes. So the exaggeration of adduction and external rotation, whose protractantry shortening, Trendelenburg sign is possible. So that is about Coxa-Vara, but all findings need not be there. There can be few, and you have to actually with your logic to justify that. So in an unstability, exaggerated range of movement, Trendelenburg sign is positive, Trendelenburg gate, telescopy is positive. In a protrusion, these are the four diagnoses which you have to make. You can make few of these. If it is a protrusion, there is a unidirectional range of movement. The other movements are, because of the femoral repeatment, there will be restriction. And the more is mitochondrial test, you have to say about the rectal examination which I did do. So the common mistakes are bilaterally don't, because all students, they are all fond of telling only avascular necrosis. So tell about other diagnosis. If it is bilateral hip, don't straight away jump to a avascular necrosis. So inflammatory arthritis, you have to tell in detail about the history, as well as you should check about the chest expansion, find out all these things. A bilateral hip without chest expansion in any individual, it is unpardonable. Right. So these are basic things which you should not. The sacroiliac joint and chest expansion. Then why there is pain in non-union, don't say avascular necrosis, because this is 5 years post-trauma, still the head congruity is maintained. It will never go in for. Only the pain in the avian is loss of the sectoral collapse, incongruence, secondary arthritis, pain. So there is no pressure, increased pressure, and there is no loss of congruity, because the weight bearing doesn't happen here. The weight bearing happens here. So it is only the capsular structures which acts as a weight bearing structure in transmitting the movement that produces pain. So investigation, you just tell the relevant investigation, have a good management plan. So to conclude, have a good brief history and a thorough clinical examination. Whatever your friends or your other people tell clues about your diagnosis, don't just get into it. You have to examine completely and then justify all the findings. So you may be able to find more findings in the science, because the postgraduate might not have examined everything, and in the exam those findings will pop up. So try to examine very well. So a good clinical examination, clarity in presentation, case sheets with the differential diagnosis and appropriate investigation, and have a very good management plan before you come. Don't say that I'll discuss with the patient and then I'll tell you what is the finding. What you have been doing is what evidence. That is what the question will happen. So best wishes and in the examination. Thank you. If there are any one or two quick questions, otherwise I think we'll directly go on to the clinical question. Anything?
By finding a postgraduate, Dr. Arun Kumar. I invite to chair the session. I call upon Professor Selvaraj sir, retired as Dean of Kanyakumari Medical College, Professor of Orthopedics MSc, formerly Professor and HOD of Orthopedics Stanley Medical College. Sir has completed his D. Ortho from Stanley Medical College and MS Ortho from MC. He's been the past president and secretary of PNOA and founder secretary of Mmc Ortho Alumni. Sir is an active cricket player and passionate cyclist. I invite Professor Anthony Vimalraj sir, Professor of Orthopedics, Institute of Orthopedics and Rheumatology, MMC. Sir, area of interest, arthroplasty and complex trauma. Sir has completed his MBBS from Tirunelveli Medical College and MS Ortho from Madras Medical College. I invite Professor Saravanan sir, Head of the Department, Tirunelveli Medical College, Treasurer of Tamil Nadu Orthopedic Association, Observer in Tamil Nadu Medical Council. Sir has special interest in trauma and arthroplasty. He is the regional faculty for PG teaching course and is received the best doctor award at RGH in 2018.
Basically, painted by architect from Tiruvallur, presented with the complaints, complaints of pain over both hips, left for past 4 months, right for past 3 months, and also having complaint of sharpness of lips lower lips, and complaints of limping for the past 3 months. History of the units. Patient was apparently normal 4 months back. Then he developed the pain over left. Then after for 1 month, right hips. The pain which is initially announced and gradually progressive, the taking type of pain is observed with walking and removed by taking rest. Pain is not associated with night rise, rest pain. Pain is not associated with diurnal radiation. This is more radiating, there is more effort pain. Patient is also having complaint of shortness of limb, left lower limb, which is initially announced and gradually progressed over 3 months. Patient is currently walking without any walking weight. Patient is also having a complaint of limb pain, which is initially onset and gradually progressive over 3 months. and patient is also having complaint of limping for past 3 months, sir, which is insidious and onset and gradual progressive over 3 months. Patient is able to walk without any walking aids. Patient is also having a complaint of burning inflammation for past 5 months and also having a complaint of frequent watering of eyes and redness of eyes for past 4 months. And, and there is no history of evening rise of temperature, there is no history of weight loss, there is no history of cough and cold, there is no history of lower back pain, sir, there is no history of breathing difficulty, and there is no history of neck pain, sir. There is no history of trauma. Patient is having a difficulty of carrying out daily day-to-day activities. Patient having a difficulty climbing upstairs and downstairs. Patient is not able to sitting cross-legged and squatting.
Physically complete or implementary activities. Complete.
There is no history of multiple small joint pain. There is no early multiple.
Pain is limited. Because depends in the pain. What are aggravating and relieving factors?
When the patient is working and walking, in the initial few steps, the patient is having less pain. As the patient is walking more steps, the patient is having a pain. The patient is able to take a rest to walk further. No early morning step, no respite.
Anything more you want to add on the limping? Can you elaborate on the limping?
After few weeks of pain, patients started having a limping. The limping, which is painful limping, the limp has progressed over time for past 3 months, and the patient is able to walk without any walking aids with the limping.
With any other symptoms?
Also normal.
Yes, no whole complaint. Only patient has.
Either history ask the male patient. This is the topics only males. Again, half the answer. Yeah. Also, in a male patient, was those rare. Though your history is very clear, pointing to what pathology could be, but for exclusion, it was also in the history.
Concentrate on the positive histories when you start. And then you have to give the negative histories to rule out the other hip pathologies. So that we have a clear idea where you are going to do this.
Hospital admission for any other condition. And patient personal history, there is not alcoholic, not smoker.
So go over the extensor aspect.
It is both the extensor and both.
Or the extensor and the flexors and go over the.
Yes.
Which is correct.
There is no history of similar complaints in any other family member. There is no significant family history.
What family history did you ask?
Whether the patient family members having similar joint complaints and pain over the multiple small joints and any similar skin lesions over the siblings and the other bodies.
Not thinking about an informative technology. Which family member will be more possibility of having these symptoms? So mother may be having, other than the mother, who may be there? You have to ask for the brothers, uncles.
Chronic bilateral progressive pathology of both hips left more than right, probably due to inflammatory areas. Like infection,
Reactive.
reactive,
Reactive arthritis.
But, the thing is, you have given history only for 4 months. But the current rotting, what we see from the side is quite large on observation. So, what do you think? Do you think such a large bunch of can occur within 4 months? Are you sure it's only 4 months?
patient is moderately built, moderately nourished, no pallor, no interest, no clubbing, no cyanosis, and no generalized ligament laxity, no laxity, no neurocutaneous markers. There is a hyperpigmented lesions present over the upper limb and the lower limb and the over the trunk areas. Polydactyly present over right hands. Then there is no general significant findings in general examination. Effective examination. Examine the patient in standing, sitting, and supine. Standing, head center, left shoulder is at lower level when compared to the right shoulder. This is scoliosis towards right side. And left, there is no exaggerated lumbar lordosis standing. There is left anterior superior index spine is supposed to be at lower level when compared to the right. Hip at neutral position, knee at extension, left ankle at equinus position. And in sitting position, the both shoulders are equal level. There is no scoliosis. Both anterior superior index spine are equal level. The left knee joint appears to be slightly posterior when compared to the right knee. In the supine position, there is no exaggerated lumbar lordosis. The left anterior superior index spine is at higher level when compared to the right side. Hip at neutral position, knee at extension, and ankle at east position. There is left lower limb is supposed to be slightly more externally rotated when compared to the right side. And there is a thigh muscle wasting present, calf muscle wasting present.
Which is more external rotated. See from footer, it is very obvious. The lateral border of which foot is touching the mouth.
Right.
Right. Left is of the mouth. So which appears to be more right appears to be more externally rotated. It is.
There is a starting of left lower limb present.
Agreed.
Inspection of left hip joint forward. There is no scar, sinuses, dilated veins, visible pulsation present over anterior, lateral, and posterior middle aspects. there is no stopwatch triangle fullness. And left, there is arbitration of supporter content hormone is present on the left side when compared to the right side, and there is no visible mass present over the posterior.
No positive finding except muscle based.
On the left side. On the gluteal side. Okay.
This shadow is take this.
My specific findings are confirmed with validation. There is no exact number notices. Left anterior experience appears to be at higher levels compared to right side. There is no warmth. There is a tenderness present over the base of corpus triangle. The femoral pulsation present equally over both sides. There is no palpable lymph nodes. Trochanterus appears to be there is no broadening, there is no thickening. There is the surface of trochanterus moves, and there is a proximal and posterior migration of trochanter, left side of trochanter when compared to the right side. On the posterior aspect, there is no globular mass present, and there is no sacroiliac tenderness present. There is no lumbar spine tenderness present.
There are joint tenderness. Anterior, posterior, anterior joint tenderness.
Both anterior and anterior.
Would you look at the anterior joint line?
From the building point, just 2 centimeters below one, lateral to the building.
Posterior.
Posterior joint line, the line drawn between the posterior iliac spine and the greater trochanter, lateral 1/3 and medial 2/3 between the line.
No mass.
Both anterior and posterior.
Okay.
Proximal and posterior migration.
Proximal and posterior migrated. What is it due to? And why should it migrate posterior? It should shift posterior. Imagine, when does the trochanter move forward when you move the hip? Which position does it move forward? Which position does it move posterior? External rotation. Right. Tell us about the other wheel. When other side seems to be more external rotation than the left. Oh, we're telling it in comparison to the right side. That it is more exterior. Right.
Also mic equipment. And here.
Now, you fix conversation. Okay, then what next? Movements. What before movements? You have to define the starting point, you know. If your the starting point movement is 0 in all planes, then we can straight away go to movements. But as per your statement, the starting point is not going to be 0 or neutral in any plane. So we must define the deformities first. That will be the starting point for your movements.
There is a fixed adduction deformity of 15 degrees present. Fixed external rotation deformity of 5 degrees is present. There is no fixed adduction deformity.
Can you show us the adduction?
Yes. Same rapid treatment. Yes. On the right side part. Yes, sure.
He is presenting as if it's a left pathology, and then when examining the hip, he wants to say that that's also involved. Is that right? But
It's the inspection.
Inspection of the right hip. There is no scar, there is no sinus, there is no dilated veins on the right hip, in the anterior, posterior, and the lateral and middle as well. In the palpation, sir, there is a tenderness of base of corpus triangle present over the right side. There is no palpable lymph nodes. There is femoral pulse felt equally on the both sides. Laterally, there is no blotting, there is no thickening, there is no migration of trochanter on the right side. There is no petrochondric
now the
tenderness.
point comes. So bilateral pathology, how do you say one is not migrated, other is migrated? You are telling that left was migrated, and right is not migrated. Right is also pathological. So you want to assume that the right trochanter is the that you can say, but here you cannot say that on the right side it is not migrated unless you draw what line? Lateral line. Because you cannot tell that this is not migrated and this is normal position. Okay.
Palpation of the right side. There is no there is a mitochondrial tenderness present on the both sides. Both the aspect, there is no globular mass present, there is no sacroiliac joint tenderness present, there is no lumbar spine tenderness.
About level of KSI.
Anterosynthetic iliac spine is higher level. An anterior joint. Yes.
Yeah, one. Go to the deformities in the left face. There is one out and Singy and Menon. The bilateral case, when they start presenting as if they see only hip and then after seeing other hip about the pathology, or candidate can commit in the initial stages of the examining one of the both hips or problems of bilateral case. Which is the best way to go about whether the examiners not ready.
So usually if the patient's symptom is patient symptom is on only one side and he says that there is symptom only on that hip, he will present and then he says at the end that the examination of the other hip, I thought there is some problem. Either the hip that starts first, he can present first, symptom wise.
Either the hip that is chronologically the first hip to get affected, he can present that. Or he can take a choice which is the more badly affected hip and present. So it's good to present inspection and palpation on both sides. And then movements you can also say on the left, this is the flexion, on the right, this is the flexion, and present it like. Both are right. Both are right. Because sometimes, in that case, sometimes it's better to tell it separate so that the examiner gets an idea how one hip is and how the other hip is. Here, obviously, you have a lot of findings. It is good to say flexion on this side is 20 degrees. Yes.
Talking as you.
Trying to demonstrate the adduction deformity in the left hip. So you are moving the right hip then.
Just to start to occupy the left limb by affected the right.
You are very clearly told how to bring out an adduction deformity when the pelvis is not square. Right? You have to take the limb to range of free available adduction, exhaust it, and then try to bring it back to neutral.
See, palpating both the ankles separately. The left is at higher levels compared to the right side. I'm keeping my thumb in the anterior leg spine. So, adducting the
Very painful for the patient.
adducting the left limb.
Final now.
No, not straight.
Can I tell you another less painful way? Keep your hand under both. Now, now move it. How do you know the position of the other is? Keep your fingers like this. Yeah. Same level?
Yes.
Yeah. Now keep the limb down. Keep both the limbs down. Starts moving now. Keep it down and then measure the angle.
Arun, here you have a unique problem, isn't it? Because the pelvis is tilted and it's a bilateral hip. Now, it is possible that one hip, the ASI is high. It is also possible that the opposite side ASI is low, isn't it? How did you now assume that there is an adduction deformity on the left side?
The movements are the opposite.
No, when you say a deformity, what does the word deformity mean for you?
Patient is not able to bring to the neutral position. Now the anatomy,
If there is an adduction deformity, what movement is lost?
reduction is
Abduction is lost. So that is the first thing you should test in a bilateral hip. Because the pelvis is tilted, it's not that one side has gone up. There is only pelvic tilt. It could be one side gone up or the other side gone down. So on the left hip, if you find abduction is not possible, most likely the pathology is that side and there is an adduction deformity on that side. I hope you are understanding what I'm trying to tell.
Clear to the other postgraduates. What Professor Menon just now said. Bilateral hip, how do you know that one hip is in abduction or the other hip is an adduction? Just try the opposite movement. The opposite movement is absent, then that is the one that is at fault.
palpating the anterior joint. Just 2 centimeters below and lateral to the medial transfer. When you are going better in line to the body. Parallel.
Talk a bit loudly so that they will be able to hear.
Placing center of my goniometer in the anterior joint lines, which is midpoint of medial point, 2 centimeters below the lateral. One is the line of the body, other is line of the
See, all of you must be very familiar with using the goniometer. If you use first time in the exam will easily spot that you have never used it. Because I have seen PG struggling to position the center of rotation of the goniometer correctly in the exam. Exam will easily find out that you never use one. Because your routine day-to-day class exam, The faculty will accept your visual assessment of the deformities. But in the exam will ask you to show how to use the goniometer. 20 degrees of reduction. Okay. Then proceed.
There is a TFX rotation deformity.
Pixel, so which method will you employ? Log rolling, singular stepping, 3 methods.
The flexion,
Hip and knee extension, hip and flexion,
input reduction, and extension. And the prone position and different position.
prone. Prone position, you put the patient and then you found out there is a 5 degree of fixed external rotation. Will you be comfortable lying down prone? This patient was he comfortable in it? Did it in prone position? I am asking you whether we can demonstrate or painful, we can skip the step.
There is a pain is present.
Pain is present. Welcome Ismail, President of TFOA, former Director of Institute of Orthopedics, and my colleague during PG days.
Log rolling method.
A log. It's a wooden log. Just like a wooden log. Log, you roll it. You don't lift your leg. Just a wooden log, how do you roll it? How will you roll a big wooden log? If there is a wooden log, you want to roll it like this. Don't lift. Okay? That's the log roll. Just as if you are rolling a log up. Right.
Painful. Are you take neutral? Just start of neutral. And whenever you do this movement, you must always have an eye on the anti-sympathetic spine because you may tilt and then you may feel a false sense of rotation. Always have an eye on the anti-sympathetic spine, try to stabilize it with one hand. There is 5 degree of pixel, rotation on the left side. Fine.
Flexion.
Flexion. Do it gently.
Further external rotation was it?
Yes.
Yeah. Only the external rotation, further external rotation.
When you touch anything, you are observing anything else.
This
In the limb. When you press, you will look for anything else. The head is deformed. There is an axis deviation. There is an axis deviation.
What's the accelerator?
Is there an exaggerated exploitation or is it normal?
Will you when you tell about the movements,
The available range of moments.
Okay, what is available range you will tell, then
Is it associated with plane versus
correct. If superficial joint, anything else? Deep joint, you may not be able to feel that. Superficial joint, when you move, also feel for any crepitus, correct. That will you put the center of the article cartilage.
Any movement. Start with the fixed deformity, then you will tell about the range of movement in that particular breath. And then whether it is associated with pain or not, whether it is associated with crepitus or not. And whether it is
In how much of active range of movements is present and how much of passive, further passive movements is present, how much is the restriction in that place? And 0 to 1. Throughout the range of movement, patient is having a further flexion. While moving, holding.
Hip is asking hip
so crepitus is when
in the hip.
in the joint, the joint.
Difficult to. I don't think I have palpated crepitus in the hip joint.
Okay.
Substitution deformity is present. Further reduction of degrees present. Movements on the right hip. Not able to move because of the leg. Movements on the right hip. And abduction of 0 to 40. And then on the right side, further abduction is pain. Abduction 0 to 30 degrees. The external rotation is 0 to 15 degrees is present. Further external rotation is pain.
Internal rotation 45 degrees on the right side.
Also know that further external rotation is being set beyond 40 degrees. Normal side, probably normal side. The same painful feeling that some of the pathology and the right person. So if you say you said 0 to 40 degrees of external rotation possible on the right side, and further external rotation you said is painful. So when you say painful, we presume that it is some pathological condition.
External rotation is
ಕಾಲರ್ ಮೇಕ್ ವರ್ಕ್ ಆಗಲ್ಲ ಸರ್.
That will come to neutral. We're able to bring it to neutral. Just about 5 days short of neutral. Okay. Not 5 days. 3 days, I would say. Okay. Further.
There is no feeling of control 45 degrees, no control pressure at all at the right. Examples right degrees. Hold it out of the tension on the scale. Possibly. Right.
The limb is already nearly 5 6 of rotation. Any further extension is possible. And there was no internal rotation. So you shouldn't make a mistake on this call. Yes.
One more small point around. If you have got an adduction deformity, external rotation deformity, it's very unusual not to have a flexion deformity. Especially in a painful condition. I'm a little skeptical about zero. Very unusual. Not able to see, not able to hand up, and because the way he was lowering his leg, it looked like he had a exaggerated lumbar.
We do the almost.
Keep doing it. Don't go the other side so that you can put his hand under that, right? Ask him to put it under his head. Now see whether there is logos. Go for 3 steps back.
You able to see? Yeah.
Let's see. Not able to ask my knuckles. Ask these fingers.
Start with looking for the deformity on the left. Flex the right and see how much left is more involved, correct?
Why is the pelvis required for normal reproduction test? Sir, it is not necessary. That's what I was trying to say. Thank you.
Examiners will try to mislead you and take you the wrong track. Don't get the you need to do the right answer. You lost. Sit, then you change. They just want to know how confident you are in your answer.
Please go on.
Keeping my hand under the exact. Yes, all of my the other lip, the larynx is already outdated.
here it looks like there is a lot of superficial.
But
I agree, it's painful. That,
the lumbar spine is resting on my hands.
When you're trying to obliterate the lordosis, you should first lift nicely well, and then listen until it is just touching your as much as possible, and then slowly come back. It's just like how you check the movements in the other places also. You understand? Okay. You can and compress your, and then you slowly lower it until it just touches the belly. That's the point you take. Okay. So you think there is no lordosis? No exaggerated lordosis. There is no exaggerated lordosis. We say there is always a normal lordosis there. If you say no lordosis, then it means you are committing that there is some stiffness in the spine. So there is no exaggerated lumbar lordosis. Okay.
Proceed.
There is a true shortening of left lower limb of
Apparent first.
apparent shortening of 1 centimeter percent over the left lower limbs, and there is a true shortening of 2 centimeter percent over the left lower limbs, and compared to the right lower limbs. And there is a 2 centimeter of muscle wasting present over the thigh segments on the left side. And
Where is this real shortening? Base of Ryan's triangle is 2 centimeter shortening on the left side, but compared to the right, so no shortening. And both tibial segments length is same. Femur segment on the left side is 2 centimeter shortening.
sorry, you said that you are able to bring the pelvis to, you are able,
Yes, sir.
you are able to bring the limbs into identical position.
Yes, sir.
You are able to bring.
Yes, sir.
What about the other side? Have you shown right side?
It's a movement on the right side.
Have you shown?
No,
You're going into measurement, so before that, we'd like to know the movements on that.
You was telling you only know that only 40 years of builder rotation and then we stopped it.
So complete the movements on the right side. That was.
And the movements on the right side, sir, there is 0 to 120 degree of flexion is possible, sir. Other flexion is painful. And there is 0 to 10 degree of internal rotation percent, sir. Further internal rotation is painful. 0 to 30 degree of external rotation percent. And 0 to 20 degree of abduction percent, sir.
So we already decided that the external rotation was fixed at 5 degrees and further external rotation was possible. The moment you say there was a fixed external rotation, we assume there is no internal rotation.
You only
You only demonstrated it previously. I just told you that. Yeah,
Examine rotation.
but it is, you are not demonstrated. There was no internal rotation when you demonstrated.
You are not able to demonstrate to the examiners.
Okay.
There is a fixed external rotation deformed here 5 degrees. Further external rotation here 40 degrees percent.
The moment you say that, we expect you not to talk about internal rotation at all. Okay.
There is abduction of 0 to 20 degrees percent. Further abduction is painful and restricted. Abduction of 0 to 30 degrees percent. Extension 10 degrees percent on the right. It was painful when you try to examine the extension on the left side. Try to lift the limb, patient is having pains. And apparent measurements, the 1 centimeter shortening present over the left lower limb, sir. And compared to the right side, there is a 2 centimeter of shortening present over the left lower limb, compared to the right side. The muscle wasting of 2 centimeter present in the thigh segment of left lower limb, sir. And this is supratomanic shortening of 2 centimeter present over the left side, compared to the right side. And
all this, both tips of technological, correct? Now, how can you comment on the Brian's learning when both tips of technological? For Brian's measurement to be taken into account, 1 year should be normal. You agree or not? That's normal. We can't talk about the Brian's line.
do the Nelton's line, sir.
What happens to the Nelton's line on the right side?
The right side, the tip is line is the tip is below the line joining Nelton's lines. In the right side.
It can be either at the line, or above the line, below the line.
The tip is just below the line of the below the Nelton's lines.
So what's the inference which is below the Nelton's line? Normally, we draw a line, Nelton's line, that's the tip of the trochanter. That is normal. If it is overreading, there is sharpening.
Not vastly below the lines, just below.
You want to take it as normal side. Is there any explanation for that? Trochanter to be below the Nelton's line?
Fraction.
Under the
Most of the level.
Okay, because if it's almost tell that it is at the level, don't tell it is below the level and get into trouble.
No inference for below the level. That's what sir was saying. When you say that, we assume some other issues. We assume that a trochanter has been fractured and it's displaced movements or something like that. Okay. So how do you draw the Nelton's line? I mean, first explain how did you draw the Nelton's line?
Place the patient in the lateral position. Flex the hip to the 90 degrees.
You flex the hip to the 90 degrees. Yes.
And then validate the ischial tuber.
Okay.
And line joining the anterosuperior leg and the ischial tuber. Join on lines. Like palpated along the femur shaft and just the there is a loss of.
So, what other tests will you do for a bilateral? One test is Nelton's line, one is Schumacher's. So, in this case, by drawing the Nelton's line, what is your inference?
Ordinal plus below the line. Again.
Okay.
Right side,
The right side it is not migrated up,
Right side is
migrate.
not migrated up.
not migrated.
No, not right side.
Okay, what happened to the left side?
The left side, the tip of the trochanter passes. Tip of the trochanter passes above the Nelton's line in the left side.
Above the Nelton's line.
Yes.
Rather, if it is the line passes,
Below the Nelton.
but it doesn't pass, and that's already there. Okay.
Schumacher's lines. On the right side, it crosses at the level of umbilicus at the midlines. In the left side, the Schumacher's line crosses below the umbilicus.
So what is the inference on the left side?
This is supratrochanteric shortening is present.
There is a process of migration of the tip of the trochanter. It's a process of migration of the tip of the trochanter when compared to the opposites. And in the right side,
Right side crosses at the level of umbilicus.
so it is,
Other side is, there's no.
you assume that other side may be no. Okay.
Chinese parallelogram is converging towards the left side.
How will you draw the Chinese parallel?
Join the line connecting under both anterosuperior legs and the line connecting the both greater trochanters. Tip of the greater
Tip of the greater trochanter.
converges towards the left side.
Normally it will be
Parallel.
each other. If it is converging towards one side, what does that mean?
This is the proximal migration of the greater trochanter on the other side and the converging side.
It is on the converging side, that's the proximal migration. So where it is converging?
Left side.
It's converging on the left side. Let us assume that the patient has had a bone grafting from the anterior superior iliac.
What do you do? You cannot
You cannot draw the cheese line. You just say, I cannot draw the cheese line because it is not. So you should be ready for all sorts of such things. You should not get surprised by this. If you say that you have drawn the cheese line in such a case, then you will get caught. That's what it is.
chest expansion is 80 centimeters.
Yeah, you're done with the physical examination.
Measurement.
Before movements, measurements. Oh, to the measurement, you want to bring in the chest expansion as well. Yeah. So that's
You need not tell that at this special test. Telescope is negative. Sir. Connection deformity. And I have to take like raising this off on both sides. If you are able to do. There is no tenderness. Yes, sir. There is no intervening giant tenderness.
How will you do that telescope test? There are all set of the lines. On the right side.
Have to bring the it to the function.
You should actually come towards the side from which you are going to demonstrate.
go to the right side of the page.
Go to the right side of the picture. Please always do it to the side from which you are going to. Yeah. Okay.
Touching the hip and bringing it to the elections. And
Is there any particular angle you will focus on of flexion? Okay. Why do you want to adduct it? Great, doctor, is just to make the trochanter prominent. Okay.
touching and electing. Keeping my thumb over the anchor superior spine. My fingers over the my index finger over the tip of the greater trochanter. Then we pulling the limb.
It's not fully down, it's a push pull. You just push and you will also pull. So what will you actually see? What will you actually feel for?
I'll place my index finger in the tip of the greater trochanter. I'll feel whether the trochanter is touching my middle finger and I'll for the migration of the life cycles.
If the hip is very painful, or if there is a, let's assume patient is not able to flex beyond, without body degrees of flexion, you will not attempt. Is there any criteria where you will not attempt it? Able to flex the hip beyond 20 inches, you will not try to do it. But is there any other reason why you will not be able to do it?
What's the person of the next thing you will get?
It doesn't happen in adverse at so the point doesn't arise that. If the patient is having a physical abduction deformity, you will not be able to do it. Not really difficult actually. You can't feel the protection.
The obese patient what will you do? Place the patient in the lateral position. You know, you hold that, get a position. Hold the thigh, hold the body on. Push like this.
You can't hold the hand, that's what Sarah is saying. When the patient is worried, you will be looking. When the patient is very obese, you will not be able to hold the limb with the fingers. You have to encircle your entire arm around the patient, and then do the push-up. That's all. Okay. So all these are practical problems you may face in the exam purpose. That's what it happens. Then, what other tests you were saying? One is the telescoping, then we want to go to the tendon. Any other test you were saying?
Active straight leg raise.
Okay. Demonstrate the active straight leg raise. You said it is possible on both sides. Yes. First demonstrate on the right side and then on the left side. Is there any significance of the straight leg raising test? What are you trying to say by that?
There is any discontinuity and the patient is not able to.
If there is any discontinuity in the limb, the patient may not be able to do the straight leg raise test. Any test, no, you should first explain things to the patient. Otherwise, your demonstration will become wrong. The first thing you should do when the examiner is asking you to demonstrate, you should not ask the patient lift the leg. That's not how you go about it. You first tell the patient what you want him to do, and then you ask the patient. Okay. Otherwise, it will come out wrong. Yeah. Normal straight leg raising, how much is possible?
More than 60 minutes.
It should be at least 60.
Anybody in the crowd, will you observe anything happening to the right lower limb when you did try to do the SLR? Ask him to do again. Yeah, we'll see now. Is the leg really straight? There is 10 degrees of 5 or 10 degrees of what? This is the so-called typical extensor lag. Also, keep it down.
So actually, he's not able to do a full straight leg raise. Okay. He is not commit like that. It's actually not all. So why do you think not being he's not being able to do? He's not actually reached the degree also.
That's the pain over the.
One is pain. Yes. Another thing is obviously there. What is the obvious reason why he's not able to do it?
The weakness.
Because of weakness and control.
We don't expect that to be positive on the left side as well. Okay, we proceed.
It's not.
Other test we've been seeing is tendon test. Okay. We were not able to do the tendon test because okay, so the tendon is painful and adduction deformity. What are the other criteria when you will say to the examiner that you will not able to do that tendon test?
There is a shortening more than I think.
Yes.
There is any.
I was already put up the slide. There were 5 points there.
Bilateral absorber cases.
If there was any deficit in the abductor mechanism, probably. Okay, you said you are not able to do because there is a fixed reduction deformity here. Why not in the fixed reduction?
Try to do in a fixed reduction deformity. And like this is already at the higher level. Only false positive.
So it will be a cause. So you should not do it in this. Okay.
It's no continuous over the direct propagation of the cycle difference. There's no pain or the other joints, range of muscle actions. There's no distal neurovascular disease. There is no there is no lymphomalleable lymph nodes.
Which lymph node did you palpate?
So iliac.
You expect the external growth to be large in this case. It will be enlarged in the case.
Critical cases. Tubercular cases.
Typical in case of tuberculosis.
Infective pathologies like
Pathology, most in case of tuberculosis.
Its expansion is
You said 3 centimeter.
modified Chauffeur's test is more than 5 centimeters. Patients having a bipedal, biphasic, unaided, startling gait with renal components.
Is there any pathology component?
Yes.
because we expect, if it is so painful, we expect the patient now have component of pathologic gait.
Startling gait with renal burn and allergy component.
Ask it to walk because you said only one centimeter apart. You get to ask it. And that also is wrong. You said fixed reduction deformity, and you said true shortening more than apparent shortening. Fixed reduction deformity, apparent shortening always more than the. Okay. So somewhere your measurement is wrong, that is one thing. And with 2 centimeter shortening, you will not get a shortening gait. And you said, I have not done Dunderberg test. And you say Dunderberg component. You cannot say gait.
You mean to say that Dunderberg patient is able to demonstrate, but you are not able to demonstrate. That's what he's telling. You told Dunderberg test you are not able to do. But patient has got a element of Dunderberg when he is walking.
If the patient is walking, able to walk, and if not able to do a Dunderberg test, you have to do a passive assisted Dunderberg test. Because if the patient is able to walk and weight, the only thing is not able to keep his independently for more than 30 seconds. Then we cannot do Dunderberg test. But still, you can be an assisted Dunderberg test.
The point is, you are committed here and got what? The point is, you should have said, there is a fixed reduction deformity, I will not check for Dunderberg. Demonstrated.
நடக்க முடியுங்களா?
The website is a flow. Same side. Pelvis is.
Right knee is deeply flexed. Probably that's why you said as a chart you get.
What about the stance space on the left hip?
Left hip stance faces.
Reduce, just jumps.
What happens when these stance space on the left side? What happens to the shoulder? Does it go to the other side? Shoulder when he is standing when he is weight bearing on the left lower limb, what happens to the right shoulder? Right shoulder is down and raised away. He wants to have lesser weight on the more painful hip. He is taking the weight to the other side.
No, what gate they are confirmed? No, what's the gate of the team? What is the hold on to the Trelleborg component?
Will you see a Trelleborg component here? Signals very not able to actually appreciate the signal. Except the short indicator. Anyway, it's not so nice. But if you see a Trelleborg component is any pelvic sagging, does the dust in all side sinks. Is that right?
Chest expansion is normal. Will you measure the muscle wasting? Sure. Quickly hold. Okay, right.
Clinical diagnosis. Fine movements. Function. 29-year-old male take this out. Chronic arthritis of left hips, probably due to inflammatory injury. And synovitis on right hip.
Synovitis.
What is the typical position of limb in a case of synovitis? Abduction, abduction, external rotation, and flexion. Any of the components there? Restriction of abduction and rotation.
No, actually, there's a fixed deformity on the right side. That's a fixed deformity, it cannot be synovitis.
It is beyond synovitis.
Synovitis, the movements will be near normal with pain the extremes of movement. No fixed deformities. Right, so we cannot commit a synovitis in LCA.
When the position of flexion, abduction, axial rotation occurs in case of synovitis, without stretching much of the capsule, that is going to be very painful.
When there is synovitis, as I said, the movements available, there will be no fixed deformities, and the extremities of movements will be pain. That's it.
No sharpening.
And no shortening.
Here, of course, shortening may not bother, but there is a fixed deformity on the right side.
There's a fixed external rotation deformity of 5 degrees is present. And there's no internal rotation possible at all. It's not restricted, it's only restricted, not possible. So we cannot comment as sinoid. We should be very clear on that.
Okay, we'll go to the diagram.
So what do you think is the diagnosis?
Bilateral. I won't accept silence on the right side.
Chronic bilateral arthritis. Can you do inflammatory?
The left is more involved.
Left is more than right. What inflammatory arthritis? Does he have any other joint involvement? Patient is also having complaints of burning inflammation for past 6 months and a frequent association of redness of eyes and.
Okay.
To the X-ray of both ribs.
What view?
And
These are things you must take an X-ray of both hips, AP view. Right. Can I have the X-rays?
X-rays.
do we get a 2 centimeter shortening in case of retest? Upgrading. State mental patient, which is involving proximal femur and both ribs. And there is a partial resorption of the left femur head is present. The Shenton's arch is broken. There is a proximal migration of left femur about the right side. And there is a sclerotic change present over the acetabulum on the left side. And the right side, there is a subchondral sclerosis present, sir. And there is a subchondral fracture is there. And on the right side, entrance right line is maintained. And on the right side, the joint space is maintained. There is no sclerotic changes present over the acetabulum, the right side.
Acetabulum is normal on the right side.
There is a sclerosis and system sclerosis present. Subchondral fracture.
The head appears deformed, it's not head is deformed, and there appears to be some areas of sclerosis alternate with cystic areas also. So, what is the diagnosis after seeing the X-ray?
Lateral osteonecrosis of femur, more than right.
You see this much of almost the head is completely gone on the left. I think this is possible with straightforward idea.
Also having complaints of symptoms and burning of face on the leader syndrome.
Why not a post-articular?
What to do further? Yeah, we got the X-ray. We are not able to pinpoint any particular pathological diagnosis based on this. What do you want to do? Blood investigations.
Okay, doctor. So, doctor, the simple thing is when you said avian, but the point that he has not contributed any history to what's the okay. Ayurvedic medications are almost 3 months.
5 months.
5 months.
Okay. 5 months is a short time for
This much of
image to occur. That's what he asked the history itself whether that's maybe further 3 months or 4 months time. And this kind of damage that will be more severe actually. Adrenal pain will be very severe. It seems to be deformed head or destroyed and deformed head. Okay. So, what investigations you want to do for the patient? Other investigations is MRI, what to confirm with the MRI? When do you want to do the MRI?
The staging on the opposite side.
Staging, right side. You mean to say. Okay.
Fracture is there.
There is submental fracture of direct collapses there. So is there any procedure you want can be done for that stage there? Okay, nothing else can be done unless it is stage one. You can't do anything for the right side here. The left side here, more than that. We are going with whatever you are saying. When you are saying that AVN, we are going with AVN. Okay. The other different, any differential diagnosis you want to give for this case? Because we don't agree with this AVN.
It is not very typical of AV. It's not very typical.
Any other differential diagnosis you want to give for this case? You want to give it as an inflammatory outlet. What inflammatory outlet is possible? Okay, let's assume that it is inflammatory arthritis. What investigations you want to do for this patient?
Total counts. Total counts.
Yeah, request a small request for the examiners because you have already run short of time. So there are 3 more long cases to be discussed. So another 5 minutes. Yeah, thank you.
Total counts. I think it is antibody.
You will do the.
Give them 2 minutes, but you have given another 3 minutes extra.
Okay, so the SI joint normal here. You said inflammatory arthritis, you have not talked about the SI joint here. Was there any tenderness in the SI joint on examination? Clinically, there is no tenderness. Okay. Whenever there is a hip pathology, will you examine for the SI joint? What test will you do when there is an associated hip pathology?
The direct palpation only.
You will do only one test. You will do the direct palpating test. See for the tenderness. Whenever there is a bilateral hip pathology, please try don't favor this for the back. It doesn't work like that. You only check for the normal tenderness in the hip. Okay. So you have done
Can you
the.
go ahead with the MRI?
Yes. Yes.
Yeah, please. Do you have MRI?
Okay. So what are your comments?
The hypointense lesions present over the left femur ribs, and there is a fluid accumulation of present over the left hips.
The right side is also involved. Is it not? Okay. Points you are learning from this. The other thing you want to learn from this. SI joint is visible, sir. SI joint is available. In the MRI. Okay. Okay.
Anything else?
I think nothing else in the SI joint. Okay. So they have given us nothing alien on that. Okay, sir. So what do you want to do with this?
Basically, painless mobile stable on the left side. Website simulated total of author class. Sorry, unsimulated total of author class.
For the right side body. Want to wait some more time or you want to do the period?
Some more time.
Because he's going to be directly make the right side, you want to give him some more time. Please do that. Thank you.
Thank you, sir. And now invite our director, Professor D. Singara Vadivel, sir. Felicitate our chairperson, Professor Selvaraj, sir. Felicitate Professor D. Singara, sir. President of Tamil Nadu Orthopedic Association, former director and HOD Institute of Orthopedics and Dermatology, MMC. I invite Professor Pasupati, sir, organizing board chairman and president of Madras Orthopedic Society, to felicitate Professor Anthony Vimalraj, sir. Sir is the past president and secretary of Tamil Nadu Orthopedic Association and chief of Institute of Orthopedics and Dermatology. I invite Dr. Suresh Anand, sir, registrar, Institute of Orthopedics and Dermatology, to felicitate Professor Saraman, sir, the Maestro, head of the department, Civil Medical College Hospital. Treasurer, Tamil Nadu Orthopedics Association.
So any other doubts from the case presented or anything else? Please go ahead, because
Couple of doubts. You can ask anybody having.
definitely, because there will be giving on, you will have doubts. Yeah, please go ahead.
For measuring fixed flexion deformity or fixed extension deformity, without any rotation, or can it possible to measure?
No, as far as possible, you have to keep it in neutral position. If it is not coming, then with that position, because definitely you will be assessing if there is an external rotation deformity. If there is an external rotation deformity, you will be assessing it less. The flexion deformity. For example, if this is the flexion deformity, if you keep it like this, then the FFD what you are measuring is going to be less when compared to what was there actually.
In exam, can we come at the measurement of density with external?
Yeah, definitely you have. If you are not able to bring it to the neutral axis, whatever axis you have.
So only thing is, you have to keep the other limb in the same deformity position and then measure for.
No, he's asking about the amount of effort. Okay. Amount of effort. Yeah.
Again, measurement also,
Measurement, it should
you
be.
have to keep the normal limb in the same position as the fixed deformity of the other limb and then make the true measurement. Otherwise, your measurement will turn out to be. You understand what I'm saying?
One more person asking question. Anybody else? That's a very good question. Yeah.
Thank you, team IoT. Because this course was first conceived in 2010. I was the first person to organize. The second course it was organized by Anthony. So it's always pleasure being part of this course.
Thank
Thank
you.
you, thank you. Thank you.
Thanks for coming all the way. Yeah. நல்ல வேலைக்கு இருக்கணும். Yeah, please.
The short case presentation will go by finding a postgraduate Dr. Lee.
Panel.
I invite panelist Professor Gautam sir, Professor of Orthopedics, Institute of Orthopedics and Dermatology, MMC, former HOD Stanley Medical College, Sir, the guidance exercise on arthroplasty, arthroscopy, sports medicine, and complex trauma surgery. I invite Professor Thirunaran, sir, Head of the Department, Emergency Medicine, Women's Medical College, Secretary of Tamil Nadu Orthopedic Association, and leading the faculty for PG Teaching Program. I invite Professor Muthukumar, sir, Head of the Department, Shengalpattu Medical College Hospital, with MBBS at Tanjavur Medical College, and MS also from Madurai Medical College. Special areas of interest include spine surgery and neglected trauma. I invite Professor Jagdish, sir, Professor of Engineering Pondicherry, the WCC Plot Fellowship and Indo-British Arthroplasty Fellowship at the Center of Hip Surgery, Brington, London. His interests include orthopedic oncology, pediatric orthopedics, and disc surgery. He has more than 75 publications and 300 podium presentations.
We have been warned that we will not get lunch to exceed the time. We have been warned, examiners. So you have to be brief, relevant history, examination findings, and diagnosis. Only important. Beneath.
Basic technician student from Jaya, rated and dominant person. Family complaints of inability to move his left elbow for past 3 years. Complaints of difficulty in using left leg for past 3 years. Patient was normal before 3 years. He is 19 years. 19 years. Patient was normal before 3 years. The patient had history of trauma. By fall by outside hand from tree and success into left elbow. Immediately after the trauma, patient had noticed pain and swelling in the left elbow. Patient was not able to move his left elbow immediately after trauma. Patient was taken to genetic bones where manipulation massage was done, and patient was immobilized with a bandage from applied from proximal third of the arm to wrist and elbow flexion. Patient had applied this gas like this for 2 cycles, 15 days once a period of 1 month, and after that patient had removed the bandage and he did not go for the treatment. After removing the bandage, patient was not able to move his left elbow with the pushing of the bandages applied. The pain and swelling the left elbow was gradually decreased after 6 months, but the patient has only pain during lifting weight. Patient was a complaint of inability to move his left upper limb towards his face, inability to use his left upper limb for his personal hygiene for toiletry purposes. Complaints are difficulty in use real results. Examination. 3 years.
Just like he is deteriorating or improving or same, except for the pain, other activities he is not good at all.
Examination. Reading center, both shoulders are same level.
Is there anything positive in the general examination?
Second general examination.
No, then go to the local examination.
The general examination, sir, the left arm is slightly deviated away from the body.
That you can put in local examination.
Left elbow. Exams of left elbow by inspection. There is no swelling, no scars, no sinuses. Almost of the mucosa is absent. Perception is less prominent.
So you have to start from the attitude. That's what you are saying is general examination. That's not general examination. That's attitude.
Right shoulder in neutral, with the arm to the side, the left arm away from the body, the elbow in flexion, the forearm in with the written finger position of these. That is flexion of the elbow present in left elbow. There is some muscle resistance in the arm, forearm, and hypothenar immense. There is no limb length. examination of the left elbow. There is no sinuses. Or not the computer fossa is absent. Person piece is less prominent.
Yes, when you do exam inspection and palpation, you do from front, from lateral side, from behind, from medial side. That's how you have to go.
Results of the lateral. There is fullness in the unconic triangle scheme. The lateral epicondyle appears prominent. There is no scars, no sinus. And the posterior aspect, there is no swelling. Medial lateral epicondyle appears prominent.
Posterior, you mean posterior or medial?
Medial lateral epicondyle.
No, you want to comment about the epicondyle or the olecranon?
First, epicondyles are prominent and posterior. Olecranon parallel appears normal. 3-point relationships appears altered.
Appears altered.
On the medial side, there is no swelling.
What is the alteration that you want? That you notice?
There is a accompanying opposite side. Both medial and lateral epicondyle systems are indications. Lateral epicondyles are indications. On the medial side, that is a medial epicondyle appearance prominent. Palpation. 6.3 findings are confirmed. There is no warmth, no tenderness present in the cubital fossa. There is a mass palpable in the medial aspect. It is
Tell the palpation from first. You're not clear. You said from tenderness, mass, where
tenderness in the present in the anterolateral aspect of the cubital fossa. Mass is present in the there is a film mass. It is present medial to medial to cubital fossa, which is not tenderness or not formed. So it can be modest, not be efficient components. It's a going hardened.
where is the mass? What to say mass? You have to find where is the location, size, shape, and everything you have to say.
It's a mass deep to the anteromedial cubital fossa below the present piece. It's a hardened consistency. It's a bony mass, bony hard mass. Not tendency. The lateral side, that is no warmth and no tenderness in the lateral epicondyle, unconius and radicular. The lateral is thickened and irregular. Posterior side, there is no warmth, no tenderness in the tip of the olecranon. Para-olecranon fossa is tended. 3-point relationships is altered. The medial side is there is no warmth. There is no tenderness in the medial epicondyle. Medial supercondyle, which is thickened and irregular. There is no tenderness or thickening in the ulnar nerve. Now, epitelial lymph node column. Movements. The elbow is fixed at 70 degrees. There is no tenderness in the radial. No normal position. There is no tenderness at the tip of the olecranon. So elbow is fixed at 70 degree of flexion. Supination pronunciation is equal on both sides.
No further movement.
No further movement. Arm and forearm lengths are equal, sir. There is 3.5 centimeter wasting in the arm and 1.5 centimeter wasting in the forearms. There is 1 centimeter decrease in intercontinental distance in the left tail bone compared to right tail. Increased inter distance in the left tail will go in left side compared to right side. So there is a increase in medial limb of the skeletal triangle in the left side compared to right side.
The distance between
The medial limbs.
the tip of polygon and medial epicondyle is also increased.
Also increased.
As well as intercondyle.
Yes.
Correct. In epicondyle, that's what you meant. Keep talking, you said wasting an arm and all.
Radial deviation of the hand is and with the proximal lateral migration of the ulnar styloid is
Once again, some clarity, manus valgus,
manus valgus. Manus valgus.
valgus deformity is there.
And with the proximal and lateral migration of ulnar styloid is
The ulna is distally migrated or proximally,
distally migrated.
which is more distal,
No, sir. Radius is more distal.
but isn't that normal?
Radius is normally distally migrated. But in case of this case, ulnar styloid is at the level of radius. Radius styloid.
That way. So both the styloid processes are at the same level. Okay.
No distal neurovascular features.
In your history, there are some
Right. Yeah, go ahead. They expose the traumatic stiffness, inherited, intercondylar fracture, the secondary is supercondylar fracture, intercondylar.
You summarize your findings, especially the palpation and movements. The other you said some mass and all. No? So just summarize your findings so that let it be very clear to everybody. So what are the exact findings in your input?
It's a mass culprit with the unprobable aspect of the flexion piece. This body artery conditions is not lateral supercondylar meniscus and irregular. Medial supercondylar meniscus and irregular. Three body point relationship is altered.
Three body point relationship can alter in the sense the distance between the olecranon to lateral epicondyle, olecranon to medial epicondyle, and the interepicondyle distance also has increased.
Increasing intercondylar distance between the medial and lateral epicondyle. Medial and the olecranon. The lateral epicondyle olecranon is same.
Lateral epicondyle olecranon is same.
Same on both sides.
So you said the inference is, no, that means the inference is the medial side has fractured or some callus has formed.
Then lateral side there is no issue. If there is no increase, then it means that there is no problem with the lateral side. That's what you want to say.
Same body has been.
Or you want to commit there is problem or
There is a problem.
Always there should be some moderation. Okay, fine. Okay.
There is a fixed question of some readings. No further movements. And this is a measurement like arm length and forearm length are equal on both sides. The arm equal. Forearm. There's no shortening.
Like
Radial, how to say radial intact or with the joint?
That is intact. Both shoulder function.
You have made a finding saying that in both the styloid at the same level. Then actually, measurement of forearm alone is not enough. Then you should measure the radial side and the ulnar, the olecranon side, the ulnar side also. So from lateral epicondyle to radial styloid, medial epicondyle, or tip of olecranon to the styloid. Individual bone length also has to be taken. Because here, according to you, there is a discrepancy.
Finding seems to be okay.
but there is the arm segment, there seems to be 1 centimeter shortening. Because the lat left condyle is big, it seems to be probably the measurement wrong. 1 centimeter shortening, I feel is there in the arm segment. And your radial head is in position. So there is no problem with the olecranon. Proximal ulna? No, I'm in the proximal ulna. Proximal ulna. You mean the olecranon is in thickening? The olecranon. Okay.
What's your diagnosis?
Post-traumatic stiffness, myelitis, intercondyle fracture. Intercondyle fracture is intercondyle.
See, there is absolutely no movement in your elbow. So what do you call that? There is no movement at all in the elbow.
So it's called the stiff elbow, it's stiff elbow. Stiff elbow is a stiff patient's symptom. Patient will come and say, I'm not able to move the elbow. That
Joint
is
is almost
not forming.
there is no movement at all. So I call it as an ankylosed elbow. Okay, so what? So that is an ankylosed elbow. So it is whether it is painful or painless.
Painless. Lifting weights only it is painful.
So what kind of ankylosed is this? Is that? See, it is ankylosed, that you accept. Whether it is painful or painless. If it is a painful ankylosed, what do you call that ankylosed?
We call the painful ankylosis fibrous.
Oh, that's a fibrous ankylosed. Then it is a painless ankylosed. So what do you call that?
What is the other type of ankylosing? One is fibrous, the other is bony ankylosing. So here, but you have palpated also one mass which is outside. So do you think it is articular or do you think it is extra articular?
Connected to bone.
No, articular doesn't mean connected to bone. Articular means connected to joint. So here, according to you, the joint is totally destroyed and not moving. Then how do you explain this anteromedial mass that you have palpated in the cubital fossa? What is that mass? It's not there in your diagnosis. Why is that mass not there in your diagnosis?
The problem is as I have told, problem is the joint itself. Fibrous, bulky, something like that. You have recommended that there is a bony mass in the elbow. So what do you want to?
What is more likely? What is more likely with your finding that A, it is a joint?
From reverse, just to go from reverse. You tell whatever your diagnosis you thought first. Whatever diagnosis you wanted to say, you tell the diagnosis. You said some stiff elbow. No, you tell that. You go with your own diagnosis. Post-traumatic stiffness with supracondylar fracture or condylar fracture. Okay. And then? So
There is no difference between the two. Supracondylar with intracondylar extension is a
Intracondylar fracture.
Both the fractures actually are giving two names for the same fracture.
So how do you account for the no movement at the joint and some mass that you were committed? How do you want to bring that into your diagnosis?
Manipulation and massaging.
Why don't you add that to your diagnosis? Myositis also can. And do you think myositis is just a mass or sometimes it may be bridging? If there is no movement and it is painless and absolutely no movement, it could be what we call a bridging myositis, which means from the humerus it's connected to the ulna. So no movement.
Basically, so to all the purpose here, almost all the diagnoses are based on your movement, especially in the hip. But the elbow is slightly different. But here, your first point is there is no movement in the elbow. So it is ankylosed elbow. Second, the movement is whatever the ankylosed is there, there is absolutely painless. So it is a bony ankylosed. And the ankylosed is either intraarticular because of the joint method, everything is fused. Something like a infection is leg or psoriatic arthritis or something like that, and the joint is fused. Or extra-articular, okay, from connection between the two adjacent bones of the joint. So in this is case of ankylosed elbow. Ankylosed elbow, most probably because of you said that mass on the medial side. The humorous and that's what it is. So it is 93% ulna. So it is most probably an extraarticular. Okay, most probably due to the manipulation of a fracture, probably an intercontinental fracture that is also accepted because all your intercontinental distances are widened and the distance between intercontinental distances are widened. So probably because he had a fracture and manipulation, probably it is an extraarticular ankylosis of elbow. Okay, post-traumatic.
The extension of the injury in the interosseous membrane that may cause the migration of the ulna, causing the manus valgus. We should not forget, we should not miss that also. What is your explanation for that finding? The manus valgus you said and the both styloid being at the same level, not there. How is the opposite side?
Opposite side, there is no manus valgus.
Not level side.
It is radius is distal to ulna side.
No, opposite side, right side. Why has God given two limbs? So that the orthopedic PG can compare. No other reason.
Very convincing. I'm not sure if this because it has inflection. I'm not able to really see. You can't really can't complete. I don't not very convinced about manus valgus.
I think if you can see the ulnar border of the hypothenar eminence and the extension into the ulna, there is an offset in the right side. If you can see, in the left side, it is in the straight line. Yeah. So the hand is shifted that. So that is a subtle difference. Yeah.
Have you palpated both the four? Because this finding is, have you palpated both the four on both? Is there thickening, irregularity, anything? Both are normal. From olecranon to styloid, from radial head to styloid, you have palpated both the ulna and radius. They appear normal.
My explanation probably is what was the age when he got here? 16 and did not allow the spices to maybe grow to that extent, maybe it's possible. Because that he was 15 years or 15, 16, his growth was not completed. And probably at the low injury, the low elbow and myositis, probably some bicycle irritation was possible.
That should be one of your explanations. The only difference there is the growing end of the ulna is the distal end. The olecranon doesn't contribute much. That is the only catch there. But that explanation should have come from you. Either the ulna is long or the radius is short. I can't think of why the radius is short.
Very difference between the styloid
Styloid I'm not saying, but the valgus part it is. So definitely the ulnar border of the hypothenar eminence and the ulnar is not collinear in the normal side, but it's lying in the same line in the array. So that is one which is baffling. Yeah.
Diagnose no nerve deficit. What do you do, doctor? What do you do with the what will you do?
So tell whatever you wanted to say.
Correct. Answer the question, but I will
take an X-ray.
what X-ray will you take, my dear?
Posterior and lateral view of elbows.
One elbow. So let's take one first.
also said the problem before on the resist also, no? We want to take the resist also. So where is the resist?
Can we have the X-ray? Read the X-ray also.
Posterior and lateral view of radius ulna.
Because that is a better X-ray. Okay. But the X-ray was really clearer. That's well, the examiners are discussing, so there is some confusion there.
No confusion. Just confirm our diagnosis. So based on the X-ray, you just tell what are the findings in the X-ray and whether you want what is the diagnosis after seeing the X-ray. You're not audible to the other person. You speak either loudly or give him a mic. What are the findings? Just see. No, you can see the point of that. Is there a point? Your findings are accepted. Whatever the findings you are gave, I think after seeing the X-ray, we can definitely accept. So now you have to consolidate whatever the findings that you gave. You have to consolidate.
What is your diagnosis? You know, make a clinical diagnosis. You have said that there is a elbow ankylos, probably due to a myositis or heterotrophic vascular. That you can tell us the finding.
You said about the thickening of the supracondylar ridge. Okay, so there is definitely a thickening of the supracondylar ridge. Okay, can you see that? There is some thickening of supracondylar ridge. You are telling about some bony mass, which maybe the hand, I mean the APU is not very clear. Obviously, there is widening and there is no, you can't see the. There are two joints. No, you cannot see one joint here. Yes, sir. Medially also see there is a bridge and there is some thickening out here. Okay, can you see that? Medially there is thickening and laterally the supracondylar ridge is thickened. And this widening we cannot of course quantify in the X-ray. And can you see here the lateral there is a bridging between. There is a bridging between humerus and the ulna. But you can see the radiocapsular joint, you can see very clearly. And the radial cap, this almost pulsation is there, sir. So there is no flexion at all. So only the humeral-ulnar joint is affected. Then the radiocapsular joint is completely free. And you can see completely there is the connection between the humerus and the ulna.
So just one small question I have for the faculty. This is the humerus, and this appears to be the bone. This is new bone formation here. Posteriorly. But this is part of the humerus. Is this the trochlea? Yes. This is the trochlea. So this bone is there. This is the trochlea. But this is the but the shaft of humerus is coming like this, and the trochlea is remaining there. So that probably adds to whether you have an intercondylar fracture also, because this is articulated. This is the distal humerus, and it is articulating in the humerus. It has to be the trochlea.
One more point I want to say. There are a few little contradictions I want to make. This supracondylar ridge is smooth. This side. No. I understand. So this is medial. This supracondylar is smooth. There is absolutely no callus. This is epicondylar. This is trochlea. So the olecranon is not articulating with the trochlea. So that is what your problem. So this is more obvious in the APU. So here it is. Actually,
not clear. Fossa in the humerus also.
So this is not any mass or anything. So this is a normal trochlea, medial trochlear ridge, and this is the trochlea. So up to this you are able to do this. And beyond this medial trochlear ridge, the lateral trochlear ridge is not seen. Olecranon has gone up, so this is not seen, and radial head is here. So here whatever you see is very difficult because
What we are saying is olecranon and AP, I think is the new.
it's just a
90 degrees of flexion. You take an X-ray from here. Very difficult to see all the trochlea and all.
No. This is
an important thing. That makes sense.
This is medial trochlea.
That I
And
understand.
able to see up to the half of the trochlea.
Bony mass is completely blocking whatever the trochlea was there or is there. It is completely obscured by the whatever is mass.
Up to this, I can understand that this bony mass is blocking. But this part of trochlea is not occupied by the trochlear notch of here.
So this oligomon and coronoid are not in the humeral dislocation.
That is the point. So the point I'm making is, suppose we draw a line on the shaft of the radial head, and you say it is in line, then that becomes a capital.
Yeah, this is capillum.
That is becomes a capital, but that is articulating with the oligomon also.
So the oligomon
One is actually moved up.
Yeah, the oligomon is here. So this what you are seeing is capillum. So this is oligomon. This is coronoid. This is oligomon.
I think it's after 3 years with this X-ray, how you can diagnose, I mean, whatever is dislocated or something, how it is possible?
No, this medial, I am very sure. So with this X-ray only we were discussing, because I saw this X-ray, CT and everything. But with this X-ray only we diagnosed. So I was pretty sure that the medial, because even on palpation, the medial supracondylar was not thickened.
Maybe so that's accepted, because of 3 years, but that is not definitely also thickening also.
So this is medial epicondyle. This is trochlea. So this is unoccupied by any of the ulna. So you normally will not see the trochlea very well in the AP. So if you see a trochlea, it means it is not occupied. So if you see the medial trochlea rich and you see the trochlea here.
So if it is fully extension and there is no bony mass in the front, I will definitely accept all their findings. But with 90 degrees of flexion and
Yeah, that is what I'm saying. In spite of its flexion, if you are able to, yeah, the thing is, so if you are able to see the trochlea, it means that something is not there. That is what is my logic. So if you are not able to see that, so, as you keep on seeing, one view only it is very difficult. So the final diagnosis was lateral condyle fracture dislocation. So the radial head is still with capillum. The lateral condyle is fractured. The ulnar and radial head along with the lateral condyle has gone post-lateral. And there is a bridging myositis mass from the humerus to the.
now for this case, whether our diagnosis can it be ankylosed elbow?
Clinically, it was only ankylosed elbow intercondylar fracture. So that was the diagnosis made. But after the CT and everything, we are able to see.
But the capillum is very clearly articulating the radial head. Very clear.
Yeah, that is right. That is what I was saying. The capillum is intact, radial head is intact, supination pronation is true. Absolutely nothing is affected. So it has completely moved along with the radial head and it is. So you can see the some more pictures. There is some
Big lateral condyle jack.
yeah, big lateral condyle jack and it has moved along with time. Yeah.
X-ray you will suggest. For this case, what X-ray you will suggest, special view.
It is also
In this, what X-ray you will order, it is already in fixed position, fixed position from there. What X-ray you can order so that you can end this controversy.
Oh man,
Special view.
oh man. The X-ray and CT films, you are able to see that.
What X-ray?
Clearly.
To know more about details of the distal humerus.
What other X-ray can do?
So that is a thing there. So you want to get clarity in the X-ray itself, not CT. What X-ray you order, special view. Truth view. Truth view you take in this is actually perpendicular to the distal elbow, so that you can see how the arrangement, pathology anatomy of the distal humerus.
What is CT films?
And then CT.
Films.
So we will clinically, we go by the X-ray and say that there is a mass and there also appears to be some intercondylar or lateral condyle. What will you do now? What is your treatment plan? Okay.
What is the treatment plan after seeing the CT X-ray? Because what happened initially now is very difficult. And I know a lot of arguments will be there, very difficult to diagnose what happened initially. And that is not our concern also. And now given the situation, how you are going to, what you are going to offer to the patient? So that's the problem where you want to do the osteotomy. Why you want to do osteotomy here? So what's this problem basically is not having any movement at the elbow. Okay, it's not having a deformity. If it's having a deformity, then you can say correct osteotomy. It's not having a deformity as such because it's already 90-degree flexion. We cannot say coming on any deformity now. He's having problem of completely locked joint, fused joint. So the joint is fused, what you want to do now? Want to do
Why is the joint fused? Because, why is the joint not moving? Because, now tell your treatment.
There is existence of the connecting block.
So there is a block that you want to remove. Okay, you want to exercise that whatever is the fused area, you want to do a lysis and remove it. Okay. That's it. And you said commented something about the resist. Can you see the resist? Sir, I was not very convinced about the manners wellness. What is this?
This radial steroid was not connecting, but the resistant moved lateral. So the ulnar border, you just see this patient, the ulnar border was like, so we have an offset. So this offset was not there on the offset. So everyone will have the normal offset. So that offset was not there.
We're based also on the problem. Probably that also probably we can. Building the height of
No, this border is
more.
getting into that.
Yeah.
You will excise the hypertrophic ossification mass, and on table you will see whether it moves. So if his elbow joint, if his fibro-ulnar joint is normal, you will start getting some movement. If you get movement, that is the end of the surgery. If there is no movement, what to do? Which is likely here looking at the old trauma and all. You understanding what I'm saying? We said that the elbow is not moving because there is a mark. So our job is to remove the mark and then move the elbow. So if it moves there, then the surgery is a success already, and then the usual.
Especially you understand the question. So you've done whatever the excision, you get movement, fine. But even after excision, patient is not getting any movement. Now, what you want? That's the question. Right? Is there any other anything else that you want to do to improve the range of movement? Fixed on osteotomy.
No, what is wrong with osteotomy at all? If you say osteotomy, what do you mean by which bone you are going to break? Right, okay, I agree. So you are removing your excision and then you want to get the movement is not happening. Which bone you want to break?
The lateral,
The malunited lateral cortex.
lateral closing wedge.
Lateral closing wedge.
Let's say
Is going out of track. See, his question is very simple. So it's not having any movement. Okay, the hip is ankylosed or something else. The problem is not having any movement. What will you do? Suppose imagine the hip